everyone, I'm student Dr. Shubhreen, and a couple of my colleagues and I wanted to put together this H&P guide for the upcoming third years to help decrease the transition between lecture learning and clinical rotations so we can really focus on learning during rotations rather than being nervous about what we might know and might not know. Toro does a really good job of teaching us H&Ps as we've all memorized them and they're almost like a second language to us. But I think what we could all use some help with is focusing those H&Ps to any specific specialty you might be seeing a patient in or any specific location such as inpatient or outpatient that you might be seeing a patient in. So we put this guide together as a way to refresh yourself on what to expect on each rotation, and a quick look at these will help you really prepare for the upcoming month. Ideally, try not to watch all of these in one sitting because it might get a little bit overwhelming, but definitely watch the portion that pertains to your rotation before you begin so that you can look prepared and impress on your rotation. Always make sure that you focus on the chief complaint that the patient is coming in with and use these guides as, of course, just a guide to lead you through a patient encounter. Hopefully these help, and we're going to get started with IM and FM. All right, so this is the IM and FM pertinent H&P quick guide. So in an outpatient setting, you're definitely going to see a lot of well checks that come every year, follow-ups for chief complaints they might have had in the past, and then preventative care such as any mammograms, colonoscopies, vaccinations, anything that needs to be done. So you'll just see patients that are generally doing well, but you want to keep them doing well. So these are the kind of questions you should approach. Obviously, if they have a cheap complaint, approach it with an old cards HPI. Has it happened before? Always ask about their past medical history, medications they're currently taking, vaccinations, past surgical history. Family history is really important here because that's a lot of the stuff that comes up later in life and you want to avoid those possibilities. Social history is really important here. These are the types of food, drugs the patient's putting into their body every day. So you want to know what your patient's doing, talk to them about it if they're ready to talk about it, and keep them healthy so that they don't end up into the inpatient side of this. You want to look for their past doctor's visit and look for old charts. So if you're in a primary care office, ideally you've seen the patient before and you can go back into your charts from if your preceptor lets you see them and look at their last chart and see what they were here for, see if there were any changes made in their medications. And you want to write that down and make sure you ask the patient when you see them, like, hey, I see that we started these medications, how are you handling them? Or I see that this is a plan we had last time, how's it going? And then ask them, were they able to make the changes? Were they able to get through it? And if not, why not? And if they were, like, can we make more changes, make you even more healthy? So this is the kind of location where you're going to have enough time to sit with a chart, you're going to have enough time to see what the patient's been here for in the past, and you're going to have enough time to plan something for the future. And then review of systems, again, this is where you do a thorough review of systems. We've done this a lot at Toro. So general, you want to ask about their fever, chills, night sweats, fatigue, weight loss, weight gain. Definitely go over their cardiovascular issues, respiratory issues, any GI issues, GU, neuromuscular or gyne. We can also do, this is also where you might want to ask about any mental issues, like depression, anxiety, anything they might be facing. You want to do an overall screen in case a patient does need a more in-depth evaluation, and then you would be the one to provide them with the referrals. For objectives, this is where you want to look at everything, vitals. You want to look for any labs that were ordered in the past, and you want to ask the patient, did you have a chance to get these done? And if they did, then you want to look at those before you go in to see the patient and see if there was any improvement from their past labs. If not, then that's how you know how you should approach this new visit and see where they're into trouble and how you can help them improve. Physical, do a full thorough physical exam. We already have notes on that. I don't need to go over it for you. And again, do all of this in as much time as given. So read the clinic. Basically, I had a preceptor who would spend only 5 minutes with each patient, and he saw 50 patients a day, versus I had a preceptor who saw 8 patients a day and she spent over an hour with each patient. So see what your preceptor is like, see how much time they're spending with their patients, and then you aim your H&P based on that and see how much time you should be spending with the patient. And then we're going to go into more of a hospitalized type of patient encounter. We need to see if the patient needs to be admitted from the ER. So stuff like they might present with abdominal pain due to pancreatitis, COPD exacerbation, any post-op issues, chest pain, stroke, nausea, vomiting. They could show up with anything, and you need to see if this patient needs to be admitted. So this is where you do a much more focused HPI, old cards, when did it start? Has it happened before? Another thing you want to take note of is how they got to the hospital. Were they brought in by ambulance, by the law, or by family? Getting through that will kind of give you an idea of how critical the patient is. You want to ask about their past medical history, and if there's a possibility of a stroke, you really want to focus on if there is past surgical history, any recent strokes in the past, actually, any hemorrhages, any GI hemorrhages, vomiting blood, to see if they might be able to get TPA. So you want to note those down really quickly, see if that's a possibility. Then you want to ask for their medications. Focus on inhalers if they have an issue with COPD. Have they been using their inhalers more often than usual in the past few days? What's been going on? Write down all their medications, what they've been taking, what they've not been taking, why they haven't been taking it. Any surgical histories, hospitalizations, the good stuff, family history, social history, trauma, travel. Review of systems, definitely focus this based on their chief complaint, but make sure that you cover everything in case they are coming in with vague symptoms. But based on what their chief complaint is, get the really important ones out first, so that if the patient's tired, if they're going in for a procedure or anything like that, you've gotten your important questions out of the way. Always start with general fever, chills, night sweats, fatigue, weight loss, weight gain. If they're coming in with chest pain, palpitations, chest pain, radiation, where does it go? Shortness of breath, cough, is it productive? Is there blood? If they're coming in for GI bleeds or any nausea, vomiting, always ask the GI questions. When was their last bowel movement? Have they been constipated? Have they had diarrhea? GU, urinary urgency, frequency, dysuria, hematuria. Ask about GYN if applicable, and neuro if they're coming in with stroke symptoms. Look at their facial symmetry, numbness, inability to talk or form sentences, visual agnosia, or weakness. Psych, you want to look for any confusion or amnesia. If it's an older patient, definitely a lot of them do just come in for confusion. Nobody knows why. But ideally, you have to go through this review of systems to see if there's a possibility of why the neuropsych symptoms are happening. It might be more of a medical cause. And for objectives, if they're in the ER, a lot of labs and imaging might already be done. So you want to ask the ER nurses or the ER doc if that's been done, if you could take a look at it, see if that helps. You want to check their vitals, look at their temperature and blood pressure, of course. And when you do the physical exam, start with mental status. Is a patient up and talking to you comfortably, or are they in pain? Are they alert? Are they confused? This is when you get a chance to see how a patient is actually doing. Always listen to heart, lungs, abdominal exam, and extremities, pulse, and sensation. All right, and then when you do an inpatient progress note, you really want to focus on, okay, now the patient's been here a couple of days. Are they doing better or are they not doing better? So when you do this, you don't need to do their whole HPI, old cards, smash FM, everything, because they've already been here. So you make this a little bit more focused on their overnight events. And ideally, before you go in and see this patient, you read the note from the night before and you see what's been done for them and what the goal was for them. Ideally, you read the assessment and plan from the night before. What are they being worked up for? What new medications were started, and see if they improved. So when you go in and see the patient, you ask them, okay, we started you on this. Does it make you feel better? If not, why not? Any symptoms? So it's a more of keeping up with the treatment plan and making sure it's making the difference that you want it to be making. So you ask them about overnight events, any fevers, pain, confusion, agitation. Ask them, is their chief complaint getting better? Ask them if there's a new chief complaint. Had they had any nausea, vomiting? Was the patient able to eat overnight? Here with the review of systems, it's a little bit similar to the surgery post-op. You, again, make sure there's no fevers, chills, night sweats. They're not forming any new infections. Make sure the patient is able to walk and move around and their gut is moving. Same with respiratory, you ask for a cough, incentive spirometry if they're supposed to be using it, fluids if they're getting IV or oral and how much. Have they been walking to the bathroom? Are they able to walk? Has physical therapy been coming in and checking up on them? So this is an overall view of the patient of how they're doing. You want to make sure every aspect of their care is looked at. So you also want to look at their psych. So a lot of older patients, if they've been in the hospital a long time, they might get confused or agitated. And we've learned about delirium. So you want to make sure that those kind of symptoms were also not present in a patient population that is at risk for those. So when you look at objectives for inpatient progress, this is when you again look at temperature, blood pressure, labs ordered the day before, and imaging ordered the day before. Progress note, you want to make sure what you asked for yesterday was done, and you want to make sure if there was improvement or if it got worse and why it got worse. You want to double check on everything that you ordered and don't forget about it. If the person's in an ICU, you want to look at their IV and see what kind of medications that they're getting through the IV, and if they're on a vent, you want to check the vent settings and write those down as well. When you do a physical exam, again, start with mental status. How's the patient doing? Always listen to heart and lungs. Again, always palpate the abdomen, listen to the bowel sounds, check for any pain. And if the patient's been admitted for a long time, you want to look at their skin, check for their pressure points, ulcers or anything like that. Again, always extremities, check for pulses and sensation, look out for DVT.
Okay, so this is the OBGYN H&P quick guides. It's divided into GYN inpatient and outpatient. And then on the second page, it's divided into the OB inpatient, outpatient. This is like the bare bones of kind of what you need to have when you're on your rotation. So you can use it as a foundation and then elaborate on it as you develop your clinical skills. I'm going to go over the GYN outpatient because the inpatient essentially is very similar, just a bit more condensed. So as always, you're going to start with an HPI, including old carts. Be sure to add in your questioning if it's ever happened before to the patient. And then in terms of the complaint, if they're complaining of discharge, it's very important to get as much detail as you can about the color, the odor, if there's blood, and then the texture, if it's cottage cheese, thick, thin, if there's pruritus or dyspareunia, I don't know how to pronounce that. And then if they're complaining of pelvic pain, temporality is extremely important in OBGYN in general. So make sure you ask about the pain in relationship to menstruation, as well as if they're having dysmenorrhea, dyschezia, and dyspareunia. Continuing on from the HPI, go into the past medical history, the past surgical history, everything you learned in doctoring, the past trauma, medications, allergies. And then for family history, it's important to ask more OB/GYN specific things like breast, ovarian, endometrial, and colon cancer, and then do your social history. When you get into the GYN and the OB history, it's important to ask for GYN the onset of menses at what age, because that tells you how long they've been exposed to estrogen for, if they have like problems in terms of excess bleeding. And then for menstrual period, it's always important to ask about the first day of the last menstrual period, not the last day. That gets really confusing. So just make sure you ask about the first day. Inquire about what their menstrual cycle is like. So ask about if it's heavy, light, if they're spotting, the length of menstruation, and then time between menstrual cycles and cramping. In terms of determining how heavy or light a period is, one way to do that is to ask about the number of tampons or pads used per day. Ask about the last pap smear and the results of that, and the last mammogram and results of that. Inquire about history of STIs, number of sexual partners, and if the patient is using protection or contraception. And then for all of OBGYN, always ask about intimate partner violence. For the OB history, you're going to ask the GT-PAL, and this essentially is gestation, term, preterm, abortion, and living children. Essentially, the example I gave was, oh no. Sorry, the example I gave was GTPAL of, on the left says G3P1112. That means that the patient has had 3 pregnancies, 1 full-term baby, 1 preterm baby, 1 abortion, and 2 living children. So you'll get used to using the GTPAL way of writing gestations and parida as you go on into your rotations. So don't worry about that too much. And then for OB history, inquire about vaginal versus cesarean delivery and if there are any complications with that. For review of systems in outpatient, that's all variable depending on what they complain of, but this is like the general of like what you'll most likely ask. So you'll include the general fever, chills, night sweats, fatigue, weight loss, weight gain. For GI, always ask about nausea, vomiting, diarrhea, and then abdominal or back pain. And again, as I mentioned, temporality is really important. So ask about temporality in relationship to the menstrual cycle. For GU, a lot of times patients will come in with UTI, so ask about urgency, frequency, dysuria, and hematuria. And then for GYN, ask about vaginal bleeding, discharge, pelvic pain, and then the other questions that I had mentioned in the HPI. For the objective section, most of the time, again, your physical exam is structured based off of what the patient comes in with. But for the well woman physical exam, you'll be doing this a lot if you're in clinic. And so the majority of doctors kind of go around this physical exam, but that's obviously doctor dependent. But usually you'll do vitals, you'll palpate the nodes of the head and neck, and then you'll do your breast exam, which includes palpating the axillary nodes, and then move down to the abdomen, in which you'll feel for any abdominal masses and inspect for any surgical incision scars there. And then for your pelvic exam, it's really important to look at the external and internal genitalia, make sure there's no lesions, check the vaginal wall mucosa and the color of it, if it's pale, red, pink, check if it's well rugated, if there's any discharge blood, and then do the bimanual exam to palpate for any ovarian masses. And then if indicated, you will be performing the PAP or STI tests if indicated. So that's it for the outpatient. I know it was a lot, but if you print this out and you just bring it with you, I think it'll be helpful. Moving on to the OB inpatient and outpatient. Um, these ones, I think I should go over individually because they're a bit different. But for OB inpatient, essentially, most of the time, patients are coming in because they're in labor. So for the HPI, it's kind of already like created for you because the documents will be sent in from the outpatient setting. But the HPI, just so that you know, should include the GT PAL, the mode of prior deliveries, the patient's current GBS status, and the placenta location, if they have any STIs currently, the timing of contractions, and if the membranes were ruptured. So again, this will already be kind of there for you in their chart. And then for review of systems, prior to delivery, you'll be asking about fevers, chills, fatigue, asking about headaches, blurred vision, dizziness, syncope. And then for the OBGYN part, ask about if the mother feels fetal movement, if there's any abnormal vaginal bleeding, discharge, if she's currently in pain, if she's having right upper quadrant pain, and then the timing of contractions. For ROS post-vaginal delivery, ask about pain, vaginal bleeding, and then if they were able to urinate or not. For post-cesarean, ask about incisional site pain, vaginal bleeding, urination, and then if they were able to pass gas. For any patient who had a baby and then they either had preeclampsia or preeclampsia with severe features, make sure you ask about headache, blurred vision, and right upper quadrant pain post-delivery. For the physical exam part, vitals are super important in OB inpatient patients. You want to make sure their temperature is normal, their heart rate is normal, and then their blood pressure is in the appropriate range. For prepartum patients in the physical exam, make sure you do a fetal heart rate monitoring, which will already be on the screens for you, and then cervical dilation check. The preceptor may or may not allow you to do this, but you're essentially checking for effacement and station of the cervix and then of the fetal head. For vaginal delivery physical exams, this is post-vaginal delivery. You're always going to auscultate the heart and lungs. You're going to do lower extremity reflexes and check for edema, and then if there's a vaginal laceration, just make sure that the wound and sutures are clean, dry, and intact. For cesarean sections, you're going to do kind of the same thing, auscultate heart and lungs, inspect the surgical incision site to make sure it's clean, dry, and intact, and then palpate lightly around the surgical incision site, as well as check for lower extremity reflexes and any edema. And the reason why you do reflexes is just to make sure that if they were given like magnesium, that they were not like toxic and hyperreflexive. For the OB outpatient stuff, most of the time it's going to be prenatal checks, so you're not really going to do an HPI necessarily, but if they're coming in with a complaint, do the old carts and do what I mentioned previously in the GYN HPI. You're going to Again, it's going to be a prenatal visit, so you'll already have the past medical history, surgical trauma, all the medications, allergies down. In terms of the GYN history, make sure you know when the first day of the last menstrual period is, because that's important for like dating of the fetus. Ask about the last pap smear and the results because it could be indicated at this visit. Ask about history of STIs and if they've been tested before, and intimate partner violence. Again, for OB history, do the GTPAL and then inquire about their prior deliveries, if it's vaginal or cesarean, and then if they had like a classical cesarean versus transverse, because that can be important for their current delivery. And then other important things to ask specifically is if they've had a history of preeclampsia, eclampsia, gestational hypertension, gestational diabetes, and then the different types of placenta previa and accreta, as well as vasa previa, and if they had a premature rupture of membranes previously, or if they had a GBS infection within a prior pregnancy. And then lastly, in the OB history, ask if they're on prenatal vitamins. That's extremely important, and you need to make sure that you ask that at every visit. For ROS, these are the general questions you'll ask, but again, most of the time, based off of my like experience, you only just ask things if they're symptomatic. Otherwise, it's just a normal checkup. So ask about fatigue, headache, blurred vision, dizziness, syncope, nausea, vomiting, abdominal pain, urinary frequency, urgency, dysuria, hematuria, and then if they're having any abnormal discharge, vaginal bleeding, or pelvic pain. And then lastly, depending on what trimester they're in, you can inquire about the fetal movement and if they're having any leakage of clear fluids. For the physical exam, this is also very dependent on which trimester you're in, but what's always important is to do the vitals and check the blood pressure. That's super important in OB/GYN. For each visit, you'll likely be doing a Leopold's maneuver, which is just feeling for where the baby is laying within the uterus. You're gonna do a fundal height measurement, Doppler for heartbeat. This one, make sure you're doing it for a minute because you wanna make sure there's proper accelerations within the minute. So that's why the preceptor is probably gonna remind you to like hold it there for a minute when you're doing the Doppler. You also may be doing cervical dilation checks within the 37 weeks plus. So that's something that you might do depending on your preceptor. And then ultrasound. That's really important in the first trimester for fetal dating, and then at 20 weeks for the anatomy. And then depending on what complaint they have, ultrasound is kind of used dependent on the preceptor and how they're feeling for this patient. And so, yeah, that's basically it. I know there's a lot of information, but it gets easier. And I promise if you look at this before your rotation, I think it should really help you out with just kind of getting your foundation and moving on with OBGYN. So I hope you found this useful.
Good morning, everybody. My name is Yama. I'm a fourth year medical student here to give you a little psychiatry H&P template. So you're gonna start off with the chief complaint, and just I guess a disclaimer. You're really not gonna need much for outpatient. It's mostly gonna be inpatient, so this pertains to your inpatient experience. Yeah, so you start off with your chief complaint, and then a fourth year taught me this, and the best way to initiate a conversation is start out by asking, can you tell me a story of how you got to a place like this? It's very open-ended and allows them to like express themselves in a more comfortable way. And then you're gonna have your HPI, and this is a general format that will benefit anybody until you know the specifics of whatever your attending wants you to do in a like for them. But you can never go wrong with this kind of setup where you start out with the name, you have the age, their legal status, their gender, and then go into their past medical history, and more importantly, their historical psychiatric diagnosis, and then the number of prior inpatient psychiatric hospitalizations, and then when were they last admitted, where, and for what, and then how many prior suicides they had with or without it, and whether or not they had a history of self-injurious behaviors, what methods they used, if they did try to impose self-harm, and how did they show up. This is something you'll find in your IM rotations as well. It's like if they came in, so BIBA is brought in by ambulance, and then Bible is brought in by law enforcement, or BIBF would be by family, and whether or not they're on a 5150 hold, what was the criteria for them establishing this hold, and then what symptoms they're showing initially when they're found. And then going into ROS, um, you just got to cover your bases with this, especially with, if it's a new patient and you have no establishment with them. You're gonna cover all the big ones like depression, mania, anxiety. And then I wrote them out for you. So SIGI caps, I know you guys memorize this for boards, but sleep, interest, if they have any anhedonia, any guilt, is their energy level increased or decreased, whether or not they can concentrate, how's their appetite, is it increased or decreased, how's their psychomotor function, and whether or not they have a history of suicide. For mania, we got the dig fast one. Are they really distractible? Do they show any signs of indiscretion? Risk-taking behavior, grandiosity, so they're having like just an absorbent amount of confidence. And then flight of ideas, do they have like racing thoughts? Are they just getting distracted? And then activities, are they like finishing like a whole book in a night, and then if they're having issues with sleep, are they extremely talkative? The what is it, the bread and butter like description of that is like, do they have pressured speech? And then covering anxiety, do they have any history of any kind of PTSD, any flashbacks? Are they avoiding anything? Are they hypervigilant, always on their toes? And then for all your patients, regardless, you want to always cover, again, we touched on it earlier with the depression, but, have they had any suicidal ideations at any point in time? Have they ever had a plan? Or if they ever intended to initially? Any homicidal ideations, the same thing. Have they ever had it? Do they have any intent to do so? And if so, do they have a plan? And then auditory and visual hallucinations. Any history of that you want to cover. And the biggest thing is past psychiatric history, right? So what diagnoses they have in the past that they know of. And then going into their current psych meds, and I got I wrote it in here, but you don't want to just get the names like you would in IM setting. Like, you need to know how much they're taking, when they're supposed to take it, because you really got to be on top of that when you want to get them started on their medications if they did miss it. Any past psych meds that they had, because then you can kind of get a picture of their progression throughout their medications. You can figure out what doesn't work, so if you had a go-to medication that you would in a certain case, you wouldn't use that because that, hey, it didn't work for them. We already touched on this, past hospitalizations, any past suicide attempts, any outpatient treatment that they've been involved in. And this goes into a bigger idea of collateral information, because with psych patients, you're not always going to get the best picture just from them. And you're going to have to do a lot of detective work in terms of having to, reach out to family members, reach out to former psychiatrists, reach out to former therapists. You really have to find all the pieces to the puzzle. And unfortunately, they're not always in the right state of mind to be able to give you all of that. Let alone, just the average person has trouble remembering half the things, right? So they have a lot more going on that they're dealing with, so it's a lot harder for them. So again, going back to past medical history, any kind of medical conditions that they have, that could be comorbidities, any past surgical history. And the big thing is, and this kind of touches with the direct psych history, is if they have any family psych history, right? It'll predispose them, it'll give them a high predisposition to develop some sort of conditions, right? And then social history, you want to know who they live with, if they have a job, address any stressors that they have in their lives, any legal issues. Have they run into any issues with law enforcement as well? And then you touch on the typical, tobacco, alcohol, any illicit drug use. And again, the biggest thing is to get a whole picture of the patient. So current and past use, any kind of history of dependence, any kind of history of being involved in rehabs. So all that is very pertinent to a psychiatry patient, more so than others. And then you also want to know about history of abuse. Unfortunately, this is something that comes up very commonly with psychiatry patients, and it's a very touchy subject, but you have to address it. And then never forget, see if they have any allergies to anything, and then any other medications that they have that'll help. You never know when that kind of information becomes pertinent. As for a physical exam, I mean, I made it more like, I don't think your attending will really give you one, and there's not much room for that. But if you ever get questioned on it, you got the typical stuff. For the general, the H&Ts, CV, respiratory, because you're not even supposed to come in. I mean, all my experiences, I'm not even supposed to wear a tie, let alone a white coat. So and I haven't experienced any psychiatrists, any of my doing a physical exam, but will help you out with that one. But more importantly, in the psych physical exam, what you want to pay attention to is appearance, right? How they dress, are they grooming, are they disheveled, how cooperative they are, how is, do they get agitated really easily? Do you have any signs of intellectual disability or retardation? Attitude, do they have any bizarre mannerisms, gestures, or any facial expressions that are very overt? And then, paying attention to their mood. Are they dysphoric, euthymic, euphoric? Are they hostile? What their affect is like. I wrote right there, observe emotional state. Are they expansive? Are they labile? Are they normal? Are they constricted or flat? So those are different kinds of affects you can observe. Are they appropriate? Are they not? And then going into sensorial, you want to address their level of consciousness. Are they alert, drowsy, or stuporous? Do they know where they are? Are they alert to their person, place, date, situation? And then testing their ability to concentrate. There's some you can use are spelling world backwards, or having them count down backwards from 100 using either sevens or by seven or by threes, and then months of the year backwards. Just seeing if they can focus, and then testing their memory. You're gonna have like so 3 objects that you typically go with. I go with apple, chair, and like a wall or something, and then you're gonna have them instantly recall it, have them do it in 5 more minutes, and then like testing their long term, you're gonna ask the patients about their past history, and then you can test the abstract thinking with either similarities or proverbs, and then when you're trying to test their intelligence, you could you can use you can test them on like, do you know who the current president is, or a few past presidents that are more recent, historical events like 9/11, and then testing their thought. Again, pay attention to their speech, how fast they're talking, how loud they're talking, are they talking clearly, and then what kind of thoughts they're actually having. So is it circumstantial, is it tangential, is it linear, does it make sense, or are they just going off on, uh, just again, random thought processes, or are they just spewing out a bunch of ideas that just have no connection to one another? And then the actual like content of their thought, like does it seem like they're having hallucinations? Again, you're gonna ask that earlier, whether or not they're hearing anything or if they've seen anything. Are they having any delusions of persecution, of grandiose, of erotomania, or somatic delusions? And then again, this is it's on this what is this this guideline like 3 different times: suicidal, homicidal ideations. You never want to miss that. It's very critical to always address that. And then any thought processes that involve derealization or depersonalization. Um, you want to see what their insight is, if they actually recognize what they're doing and why they're doing what they're doing, or are they still caught up in in their delusions. You want to adjust their judgment, so kind of see what their solutions are to hypothetical situations. Are they rational? Are they not rational? Um, and just see how their impulse is, right? That goes back to, are they really easily agitated or not? Um, and then again, you just want to address their medications, because medications are very key. The dosages are very like it's very important to address all of that. And that's it for my H&P.
I will be covering general surgery. I split this up by patients you'll see in the clinic before a surgery, then you'll see patients in the ER or on the floor for a consult called in by an IM or a general doctor, and post-op where you see patients after you've had your hands inside of them. So we'll be doing clinics. So what you'll be seeing here is patients most likely coming in for elective procedures or referred by their primary care for something they might have found, like a breast mass or a thyroid mass. This is where you have more time to see your patients and they're in your clinic and they're not in pain, so they'll answer all your questions. So you start out by doing an HPI, old cards. We've been doing this for years now, and just ask them exactly when they notice changes or how long it's been there, any pain, stuff like that. What's really important that you do here is get a really good history of their medical history, any past MIs, hypertension, COPD, thyroid issues, coagulation issues, any infectious diseases that should be checked for. Get a really good history for their past surgeries, anything that they might have had taken out, any complications that might have been because of it. And when it happened, you want to have all that written down for your preceptor. Any past hospitalizations, family history, cancers in close relatives, any medications they're on. It's important to ask them about their social history, smoking, IV drug use, alcohol, their food, exercise. It's all important here. And then you want to go over their GYN and OB history if applicable, and you can go through that in the OB-GYN quick guide that we've provided. Review of systems, again, this is going to be your more thorough review of systems out of any other location that you'll be seeing patients. Definitely ask fever, chills, weight loss, night sweats, fatigue, anything that might be infectious, cancerous is going to show up with chills or weight loss. General surgery is a lot of GI, so you'll see a lot of nausea, vomiting, bowel movements, diarrhea, constipation, colic, abdominal pain, hematemesis, red or black stools, and jaundice. This is where you want to go super in depth with your questioning, when things started, if they've been getting worse, if they've been getting better, if they've had them in the past. You want to get a lot of detail on talking about their poop. I know general surgery is where you get really comfortable doing that. Then you want to go into their, depending on what kind of clinic you might be in. If you're in a cardiothoracic, definitely you're going to do different types of review of systems. If you're in a vascular surgery or an orthopedics, you're definitely going to do different types of questions. We just kind of went over the more basics that everyone's going to be seeing. Definitely cardiovascular, ask about chest pain, shortness of breath, orthopnea, the basic stuff. Respiratory, same thing. If they have a cough, is it productive? Are they coughing up blood? Stuff like that. Muscular, you want to look at swelling, any heat or pain in the legs. Check for sensation changes, claudication, hair loss, ulcers, temperature differences. More pertinent to if you're at a vascular surgery clinic. That's the kind of stuff that you want to be on the lookout for. Then GU, look for urinary retention, hematuria, recurrent UTIs or dysuria. And then same with GYN, you always want to ask if that's applicable. For your objectives, you want to always check for their vitals, especially if it's for a pre-op checkup. You want to look for their blood pressure and good stuff like that, something that might not let them go to surgery as soon as they wanted. For physical exam, always listen to heart and lungs, auscultate your abdomen, do all your palpations in all 4 quadrants, definitely do extremities and breast if applicable, for if that's what they're showing up for. So all of these with the criteria that you want to be more specific to what they came in for and focus your exam on their chief complaint. But this should give you a kind of baseline for everything that you might want to look out for if you're seeing a patient for the first time or it's your first time in a general surgery clinic. And then what you'll also see during your general surgery rotation is a lot of consults where you will be sent by your preceptor to go check on a patient, see if they actually need the surgery. So these patients are a little bit more sick. They've already come to the hospital and now we're thinking they might need surgery. So you're not going to be able to ask as many questions. You're not going to be able to get as much detail, but this is the stuff you really want to do a quick look through and want to make sure you don't miss these things. Definitely HPI, of course, if they're in pain. When did it start? Focus on how the pain changed. Like an example would be the appendix, as we all know, starts around the umbilicus and then moves to the right lower quadrant. So stuff like that. There's different kind of pain that evolves. If it becomes peritoneal, it becomes much worse. So you want to make sure you want to ask when that changed, when the pain started, if the patient's not enough pain. Of course, go over your SMASH FM here if given time. But what you really want to focus on in a more acute situation is trauma, and if they're just in an accident, a recent surgical history, if they've same thing as before, any hospitalizations, if they recently went to another hospital or a doctor because of these same symptoms, and if it got better or worse, or why they're here now. Again, you want to go over their medical history, hypertension, COPD, coagulation issues. I keep bringing that up, especially medications they might be taking for hypercoagulable states, because that definitely changes your when the surgery can happen, because ideally you don't want a patient to be taking blood thinners before they go into surgery. So definitely ask about those. Again, review of systems, a little bit faster, fever, chills, weight loss, how long have they been having it? What you'll see for more acute cases is a lot of blood, if they're throwing up blood or if they're pooping blood. So you want to ask if they've been having those. Same thing again here, you want to go over a lot of their GI issues and how long they've been having it. And to be safe, always ask about chest pain and cough and shortness of breath, and if they're coughing anything up. So it's a little bit faster. So you want to get an idea, how sick is this patient? How quickly do they need to go into surgery, if they need to go into surgery at all? And you want to just have off the top of your head, you want to have these questions that you go in and ask while the patient is in the ER and is in pain. You don't want to be bothering them with what they had for breakfast yesterday, unless if it's applicable. And then for objectives here, we want to, again, look at their vitals. Always important to look at their vitals. Labs, if they're in the ER, they're more likely done. So you want to look at their CBC, CMP, A1C, those. Imaging, again, if it's already done. Physical exam here, always listen to heart and lungs again, and focus on the CC, chief complaint. They come in with tummy ache, look at their tummy, press on their tummy. Don't look at their leg if they're not here for the leg. If they're here for their leg, still listen to their tummy, but focus on the leg. So just even in the moment, think actively about what you're doing. Here, same with the abdominal exam, you're going to auscultate, check for guarding and rebound. So what you want to check for here is an acute abdomen. If you're barely touching their abdomen and they're screaming in pain, that's more acute. An acute abdomen also happens to be hard without the patient contracting their abs. So it's hard to palpation. And then tenderness, you want to look for any masses, any pulsatile masses, all your McBurney's points, Murphy's sign, obturator sign, and check for abdominal wall and inguinal hernias as well. And if they're here for a trauma or an extremity, always check pulses, check for sensation, see if the color is different, check for excessive pain with palpation of the muscles. So checking for compartment syndrome, if something needs to be done faster, that's where you're going to catch that. So this is a lot of figuring out exactly where the patient is, when they need to have surgery, and if surgery is actually necessary, or if this is something more medical that can be handled not without surgery. And then post-op is a totally different ballgame in terms of what you need to be asking them and what you need to be focusing on. So they've already had their surgery. Ideally, you've already fixed what was wrong with them. Now you want to make sure that they come off of that and actually feel better. So when you go see a patient the next day, you always want to ask them if anything happened overnight. Did they have excess pain? Were they throwing up all night? Were they able to sleep? Ideally, if you can find their nurse, ask them first before going to see the patient, how were they overnight? Do I need to be on the lookout for anything? Do I need to ask them? But ideally, you want to ask your patient too, have they had nausea, vomiting? And have they been tolerating food? Have they been able to eat or drink? Review of systems, a little bit more specific here would be fever, chills, night sweats, see if they've had any infections from the surgery. So you want to be on the lookout for those. Always ask GI questions. Are they passing gas? Have they had a bowel movement yet? Because as you know, anesthesia turns off your gut. So you want to make sure that they've started moving, because they can't go home until they've had a bowel movement. And GU, if their Foley is in place, you want to ask the nurse how much output that they had. If their Foley is not in place, then you specifically ask, have you gotten up to go to the bathroom, or are you using the bedpan? Because that way you kind of figure out, have they been able to walk? Are they in too much pain? Or are they able to get out of the bed? And you want to ask here about their respiratory, shortness of breath, any cough, have they been using their incentive spirometry? You want to make sure they're opening their lungs and breathing to avoid atelectasis. And you want to ask about their ins and outs, their fluids. Are they getting IV fluids? Are they drinking fluids? If so, how much? So you always want to see how much are they putting out in terms of urine, and how much are they putting in terms of oral or IV. So you want to ask about that. And ask the nurses, they usually have written down from their overnight how many milliliters. You want to make sure it's always even in terms of how much they put in and how much they take out. Then you want to ask about, again, have they been walking? How much have they walked? Did physical therapy come help them? Because not only does that help move your gut, it also avoids DVTs, and it kind of gives you a better gauge of how well the patient is doing. Then for objectives here, again, focus on temperature and blood pressure. Make sure they don't have any infections. Here you want to look for hemoglobin on their CBC, because if they lost a lot of blood in surgery, you want to make sure that it's not too low. If they have any increased WBCs, might be an indicator of infection, so you want to look out for that. Any A1C, and you want to look at their UA if they had a Foley placed too long. Avoid any UTIs. Imaging, if any were ordered the day before, this is where you would go look for them and make sure they look okay. Again, ins and outs, more objective, not just asking how much have you been drinking, but actually look at the numbers. How much have they been putting in and how much have they been taking out? So physical exam here is a little bit different in terms of, really want to focus on their mental state, because older patients, especially being in the hospital that long, going under anesthesia, coming out, having surgery can definitely, as we've learned, cause delirium. So you want to see, are they talking appropriately? Are they confused? Were they okay all night, or were they agitated? So this is where it's a more objective, as in you're going to talk to them and see what they look like. Again, cardiovascular, respiratory, you want to auscultate in terms of where the surgery happened. You want to look at the incision site, look if there's any extra drainage, any extra redness, if any extra tenderness, because those might be indications for either opening of the incision site or any cellulitis. So you always want to look at the incision site. And in terms of drains, if there were any drains placed during surgery, you want to see if they're still there. If so, how much are they outputting? So this is another part of your ins and outs. Again, abdominal exam, really focus on bowel sounds. Are they guarding? Any acute tenderness? Deep palpations, same good stuff. And always check their pulses and sensation in their extremities, especially after they've been in bed, to check for any DVTs or anything like that. So ideally, this kind of walked you through what to focus on in each situation and what kind of questions you should be asking in terms of when you see a patient in the clinic versus when you see a patient post-op. All right, thank you.
Hi, my name's Alia. I'm a fourth-year student, and I'm going to be talking about Peds H&Ps for both inpatient and outpatient rotations. So I'm going to start with outpatient because I think it forms a pretty good foundation for an inpatient rotation where you'll have to be a little bit more targeted and possibly work a little bit more quickly. So first of all, I have divided this huge, annoying chart into 3 categories: infants and toddlers, younger children and school-age children, and school-age children and teens. So this is kind of arbitrary. I just wanted to make it a little bit easier to present, but obviously developmentally, a kid who's 4 years old is going to be completely different from a kid who's 10 years old. So you just want to keep that in mind when you're going through your H&P. But I'm going to start with infants and toddlers, which I've defined as newborns to 3 years old. Okay, so for a well child check, you might want to go through all of these questions and just be really thorough. But if they're coming in for an upper respiratory infection or some other complaint, you will want to be a little bit more targeted and come up with more relevant questions for your H&P, right? So one of the things that you're going to want to focus on is the birth history. So you want to know if the baby was born full term or preterm, what their weight and length were, their APGARs, and also you want to have a brief history about the mom's general health, right? So you want to ask about any chronic problems she's had, like hypertension, diabetes, prenatal screens, medications taken during pregnancy, and you want to make sure that she hasn't had any infections during pregnancy as well. You want to ask about how the baby was delivered. Was it a vaginal delivery or C-section? Were there any complications during delivery? How long did they stay in the hospital? Did they have to stay in the NICU at all? That's really important to ask about as well, because you want to know about any major problems that the baby had before they came to visit you. You want to ask about any medical problems that they've had since birth, and go through their medications, including the dose, formulation, route, whether it's by mouth or by rectum, and the frequency of administration. You also want to know any allergies and make sure that they're up to date on immunizations, and that's super important. You want to keep a link to a vaccine schedule just so you can easily refer to it. This is super, super, super important. Okay, so you want to know the past surgical history, and also the family history is important as well. You want to ask about any kinds of genetic disorders, chronic health conditions, autoimmune disorders, or any other serious conditions. And then for social history, some things you want to keep in mind are who else lives in the home, right? So is the kid living with the parents, some other guardian? What kind of environmental exposures are there? Is there a smoker in the household? You also want to ask about home safety, car safety, and sleeping habits. So you want to keep these ABCs of SIDS in mind, right? So the baby should sleep alone on its back and in a crib. And smoking definitely increases the risk, so you definitely want to ask about whether there's any tobacco exposure in the house. Okay, some other things you want to keep in mind and ask about. So is the baby taking in formula or breast milk? How much and how often, and what is their daily intake? For formula, you want to know what kind of formula that they're using and how the parent or guardian mixes the formula. That's also a really important question to ask. You want to make sure that they're getting an adequate caloric intake. So you want to ask about any difficulties that they're having with feeding, like with latching. And then once they're ready to start solid foods, you want to note how much food they're getting and what kinds of food they're eating as well. For any kid, development is going to be a really big part of your exam and the questions you ask. So there's some guidelines here that you can look at and ask the parent, like, oh, can the baby flip over onto its back? Is it sitting by itself without support? Things like that. So there are different domains that you can ask about here: social, emotional, cognitive, communication, and physical components. For a review of systems, you want to ask about, for general, fever, weight loss, level of activity. Are they interacting with the parents? You want to ask about rashes, bruising, jaundice. For eyes, you want to make sure that their eyes aren't crossing, because that can lead to unilateral blindness later on if it goes uncorrected. Any redness or drainage. You want to make sure that they're able to hear. So ask about hearing loss, any ear pain or ear drainage, frequent upper respiratory tract infections, snoring, and whether the teeth are erupting and if they're having any pain. For the heart, you want to know if there's any murmurs that were heard at birth, any chest pain, cyanosis, respiratory. For GI, you want to ask specifically about feeding habits and their appetite. Are they able to keep the formula or breast milk down? Are they vomiting or having diarrhea? Constipation is a big one as well. And you want to ask about the typical frequency and consistency of the stools, as well as whether there's any abnormalities there. Another big question you want to ask about is the number of wet diapers per day. You want to make sure that babies are staying hydrated, how often they're urinating, if there's any abnormalities there as well. Okay, and then for the physical exam, this is pretty different for newborns versus toddlers, but so you can keep this chart handy. It's a chart of vitals, and that's something that I always had trouble with, was keeping track of what the normals are for infants and younger children versus older children and adults, because it's very different. For the head, you want to make sure that the fontanelles are open and flat. So the anterior fontanelle stays open until about 9 to 18 months. And the shape of, you want to make sure that the skull is symmetrical, that there's no plagiocephaly, any abnormalities that you find there. For the eyes, you want to make sure that they have a red reflex. Sorry. There we go. Okay, and then for ears, little kids are more likely to get ear infections, so you want to check for any discharge, make sure the TMs are mobile. For the mouth and throat, you want to make sure that especially in infants, that there's no cleft lip or palate, and in toddlers, you want to check for any dental caries. Okay, the rest is pretty similar to an exam for older children, except you do want to, especially for MSK, you want to make sure that you're checking for hip dysplasia in infants, the Ortolani and Barlow maneuvers, and testing for muscle tone and strength. Let's see, and also the primitive reflexes in infants, like the Moro reflex, the grasp reflex. Those are just some things to check for as well. All right, so let's move on. Okay, so moving on to younger children and school-age children. Again, this is a pretty broad range of ages, so you want to kind of focus on the developmental stages that they're in, any developmental milestones, and also keep in mind the chief complaint. So I've just listed some more common chief complaints up here for each of the age groups. So for school-age children, a lot of them come in for well child checks, but also upper respiratory infections, acute otitis media, gastroenteritis, asthma. Those are all things that you might see in an outpatient office. Okay, so of course you're going to target, you're going to have a more targeted approach if they come in with a specific complaint. Some things that you want to keep in mind are safety. So use of a car or booster seat is really important if the kid is under 8 years old. There's also the guidelines on the CDC website that you can look up. Behavior and performance in school, it's kind of hard to adjust to school at first in younger kids. So you do want to ask about that as well. And you want to screen for adverse childhood events because those can affect health later on in adulthood even. So it's really important to ask about safety at home and relationships with the family or whoever they're living with at home. And also that's really important to keep in mind are the dietary habits. So you want to ask about the types of food eaten at home and at school as well. So how many servings of fruits and vegetables are the kids getting? How many sugary drinks do they have every day? So you just want to ask about the frequency and quantities of that, as well as how much water and milk they're taking in as well. Some anticipatory guidance that you can add in. You can ask about relationships with friends, family members, ask about school, hobbies, activities, again, referring to developmental milestones when asking parents about that. You can ask about reading habits and screen time, making sure it's less than 2 hours a day, preferably less. Use of bike helmets and caution when crossing streets, and stranger danger. That's always a good one too. Review of systems is going to be pretty similar between the different age groups, except that there are a few things that you can keep in mind, especially for school-age children, like you can ask about if they have blurry vision or if they might need glasses. You can ask about their dental habits. Are they brushing and flossing regularly? Are they doing it correctly? You just really want to avoid cavities because that can have a big impact on health further down the road. You can also ask about ADHD, anxiety. Those things can present pretty early in childhood, and it's important to catch them early on. Okay, and again, pretty much the same thing for the physical exam as well. Again, kids are more likely to get ear infections, so you definitely want to check out the ears as much as you can and look for any dental caries or a need for orthodontia. All right. Oh, another important thing to do is the scoliosis screen. Okay, moving on to school-age kids and teens, you might get patients that are over the age of 21 even. So there's obviously a big range in development here, but for this age group, I think the biggest component is the HEDS exam, which focuses on the patient's psychosocial health. And that's pretty different from the other age groups. So this is the portion of the exam where you want to ask the patient's parents to leave the room. Kids this age are going to value privacy more, so you can emphasize that everything that you talk about is confidential. Be sure to ask open-ended questions and be non-judgmental as well. So the components of the HEDS exam can be broken down into home, education, and employment, activities, drugs, sexuality, suicidality, and depression. So for home, you want to ask about family dynamics, the relationship with parents and guardians, siblings, and anyone else who lives at home. You can ask about home responsibilities and chores, recent changes or stressors. For education, you can ask about how they're doing in school, how their attendance is, if they have any favorite or least favorite subjects, are they having any difficulties with learning or anyone at school, and then what their future goals are for their career or college or what have you. Okay, and then for activities, you can ask about extracurriculars, sports and exercise, hobbies and interests, friends, and religion. So these are all really important. Then for drugs, you want to ask about alcohol, tobacco, use of illicit substances, or if they feel pressured to use any of these substances by their friend groups. For sexuality, you want to ask about relationships, any sexual activity, including a discussion about safety, consent, STIs. Are they using appropriate contraception? Are they, have they ever been pregnant? Have they ever had an abortion? How are they preventing pregnancy? And also screen for history of abuse. This is really important as well. Again, you want to do that screen for the adverse childhood event spaces. Ask about body image because eating disorders can be a really big problem in this age group. Ask about sleep habits, do a quick screen for depression, anxiety, if they have any suicidality, if they have access to firearms, and whether they feel safe in their home. Some more anticipatory guidance. You can ask about car safety, what their diet's like, and obesity prevention. So in this age group, there are going to be a lot of changes physically. So you can ask about their skin. Are they having any trouble with acne? It's always good to ask about whether they have any wheezing or asthma symptoms. And then it's also really important to ask about their reproductive health. So for kids who are menstruating, at what age did they have their first period? When was their last menstrual period? Just do a really quick overview of their reproductive health. And again, psych is really important for this portion of the exam as well. Okay. Then for the physical exam, it's pretty much the same as for the younger groups, except that you're going to make sure that they are developing properly, that they're starting to develop secondary sex characteristics such as pubic hair. You're going to monitor their breast development, and you can use the Tanner stages as a guide here. And again, you want to monitor for scoliosis as well. Okay. And I just put 11 to 18 for this group, but it kind of depends. Some kids might be more independent or mature starting at a younger age, or less independent. So it kind of depends on the patient. You kind of have to get a feel for where they are in their development. Okay, so now we're going to move on to the inpatient portion, which is a little bit shorter. So you do want to keep these H&Ps a bit more targeted and relevant to whatever presenting problem that they come in with. Right, so in infants, you're going to see a lot of RSV bronchiolitis in the hospital, especially in the wintertime. You also see a lot of gastroenteritis, UTIs, meningitis, appendicitis, both pre and post-op, asthma exacerbations, DKA, and I've also seen some sickle cell pain crises. So those are kind of the bread and butter, so to speak. And I divided this into two columns. So there's, when they first present, you're going to do a full H&P, and then the next day you're going to do an inpatient progress note, right? And so that just seeing if there's any developments or improvements, worsening of their presenting problem. Okay, so for the inpatient H&P, you want to do your old carts. You can ask about the birth history if it's relevant to the clinical presentation, or if you have a patient who is an infant or a younger child. Basically, if you have a baby, you want to always ask about their birth history no matter what. Okay, so you also want to ask about whether they've had any recent SIG contacts, especially younger siblings. They're basically a petri dish for different infections. I'm going to ask about any medications, health problems, recent and past surgeries, including complications and the clinical course. Were there any recent hospitalizations, or has the patient ever been hospitalized for this complaint before? Are there any major health problems in the family? And if you do suspect something like DKA, you want to ask about autoimmune disorders that run in the family. That's something that came up a lot for me when I was doing my rotation. For social history, you want to do a little bit more of a focused social history, so you're not going to be like doing this whole thing that I've outlined up here, but it's going to be more targeted. You can ask about how the infants breastfeed, or if they're using formula, how many times a day, any drug use or alcohol in adolescence. Just keep it relevant. Same for the ROS, you want to keep it as relevant as you can. For babies, it can be kind of hard to tell, like if they're just sleepy, or if they just cry a lot. Like, does that mean that they're being irritable? Like, it's hard to tell. So you can definitely ask the parents if there's any changes in their level of activity or in their personality. Yeah, so you can ask about fever and chills, if there's any differences in their level of awareness or consciousness. So respiratory is a big one, especially for things like RSV. So for infants, you can ask parents if they've seen any retractions, like if their ribs are moving a lot when they're breathing. You can ask about grunting, coughing. You always want to ask about sputum quantity and the characteristics, and wheezing. For GI, you want to ask about whether they're tolerating feeds, if they still have an appetite, if they're vomiting. Always note if it's bilious or bloody. Are they having diarrhea, what their typical frequency and consistency of stools are. And then if a patient is post-op, you always want to ask whether they've had a bowel movement or have fasciitis. Okay, and then for infants, you want to ask about the number of wet diapers per day. For older kids, you're going to ask about the frequency of urination, if they have any pain or discoloration with their urine as well. All right, okay, so then for objective, you want to keep in mind the vitals. When you do your exam, you want to note if they look toxic, what their level of activity is, if they're alert. Always palpate the anterior fontanelle in infants to check if it's bulging or flat. And for kids, don't like being in the hospital, so they're going to be crying. It can be difficult to hear lung sounds and heart sounds if they're crying. So try to do the rest of your exam first. Do as much observing as you can, then warm up the stethoscope bell, and then you can listen, and maybe they'll stop crying. If they're on oxygen, you do want to note the settings and check out the flow rate and the FiO2. And then you want to do a quick GI exam as well. Check for any hepatosplenomegaly, any guarding, masses, bowel sounds, the usual. And then for extremities, just want to do a quick check of the pulses, look for any swelling, and then if they're on fluids, just note where the IV is placed as well. Okay, so then for the progress note, really you're just trying to find out if they're doing better or not. You want to ask about if there were any events overnight. If you talk to the nurses, they can definitely help with that. Ask the parents, were there any changes to the presentation? Like, has it been getting worse? Has it been getting better? Are they still able to breathe? Are they still able to breathe as well as they did before, or is it getting worse? Any new chief complaints that developed overnight? You want to ask about the amounts of pain meds and fever medications that they've been using to control their symptoms, and also note any changes in oxygen or fluid requirements. Okay, so for ROF, it's pretty much the same as before. Also, if they're post-op, you want to ask if they're using incentives spirometry to prevent atelectasis. Again, ask about the bowel movements and flatus. For every patient, you want to ask if they're tolerating feeds and fluids, their appetites, ask about wet diapers, again, frequency of urination, any seizures, loss of consciousness, changes in level of awareness or activity. And then ask if they're able to get out of bed and walk to the bathroom, or even if they're able to walk down the hall or to the playroom if the hospital has one. And the hospital can be a really distressing place for kids. So you can ask if they're experiencing any confusion, agitation, distress, or anxiety. Confusion could be a sign of delirium, but a lot of kids are going to feel anxious in the hospital. It definitely helps if there's a child life specialist available. You can definitely ask about that as well. Okay. Then you're going to do a quick recheck of the vitals, look for any labs that were ordered, and check for the most recent results. Same for imaging. And then you want to look at their ins and outs. So the chart usually has a list of the IVs and the amounts of IV fluids and PO fluids that they're getting, how much food they're taking in, and also their stool and urine output over the entire hospital stay, basically. So what you want to do is add up all the ins and outs for the past 24 hours and then report the ins as shown here. And a normal urine output in kids is greater than 0.5 milliliters per kilograms per hour. Okay. For meds, you want to note if there are any changes overnight. Again, note if there were any changes to the amounts of pain meds or antipyretics that they had to take. And you're going to just do a recheck of their general appearance, their level of activity and alertness, check the anterior fontanelle, listen to their heart and lungs, and then, listen to their stomach, and then again, look for lower extremity swelling. Okay, so that was a lot of information. I hope it helps. I felt like there was a pretty big learning curve for me for the Peds inpatient rotation I had, but these are kind of the things that I wish I'd known ahead of time before going into that rotation. So I hope it helps, and good luck. You got this.